Yeah, probably. And I was like, okay, I'll just leave this right now. Yeah. It's a small enough room to where. I thought about finding an icebreaker again. Like dip it back to my teacher days and be like, turn to your summer partner. So probably, yeah. I think so. Whatever. This is like 2 years into it.
Okay, I have 10 o'clock exactly, so, but we'll let people trickle in. Hi, my name is Becca Killen, and my pronouns are she, her, and I'm here mostly as a volunteer, but also invested professionally and personally, so I'm really excited to introduce our first session, Breakout Identifying Autistic Toddlers in Kansas. A couple of our panel members were not able to make it today, but we have some awesome panel members here, and they would love to have a really informative, interactive session. So just a couple of housekeeping. There are 2 exits on this one in this room. If you need anything accessibility-wise, let me know what I can do, and I will try to find the answer if I don't have it right away. We do have evaluations for each session at the end, and they tried to encourage me to have you fill those out electronically, so there's less time filling things in. But if you need a paper evaluation, that's available too. So QR codes are in your program for the evaluation. There's one up here, or let me know at the end and I'll get you a paper copy, but don't forget to do that on your way out. Oh, also, just so you know, they are recording this session right here to use for, I don't actually know, I didn't ask why, because they like to record great information. I don't think it's like going out publicly, but I
think for people
it's legit. Yeah, okay, we can be here in person, there you go, to share afterwards. So let's give a hand to our wonderful presenters.
Okay, hi everybody. I'm going to be introduce each of us first. Yeah. Okay, so I'm going to be starting us off today. My name is Olivia Boorom. I'm a Ph.D. candidate here at University of Kansas, and I'm also a speech pathologist. This is my colleague Suzanne Martell.
I'm Suzanne Martell. I'm project coordinator on Dr. Nancy Brady's latest communication in autism study, and I am a former special education teacher.
And I'm Kourtney Nigh. I am the director of Global Autism Interactive Network, which you heard about at the keynote or prior to the keynote. I'm also a research clinician, so I get to work on teams with these individuals working on diagnosing and doing assessments for disparate research studies. I'm also a parent of 2 neurodivergent children, and one of which is autistic. So I have some lived experience as well as clinic work.
Right, and the idea for today is that honestly, Dr. Soul's presentation really set us up very nicely to talk about this today. which will be kind of great framing so that we can zoom in on maybe brainstorming together some solutions for early identification and diagnosis in autism, specifically in Kansas and Missouri too. So we'll talk a little bit today about the diagnostic process, some myths that we have encountered that kind of are pervasive among providers in our community, and so we can brainstorm some ways for how to combat those, and then kind of go through the autism diagnostic process as it stands and think together about what are some creative solutions to getting kids identified and diagnosed earlier and making that a smoother process for families. And this presentation really came about because, like Suzanne and Kourtney mentioned, we work on a research study here at KU with the aim of mapping the development of language very early on in toddlerhood in children with autism. And so what that looks like for us is trying to bring kids into the lab kind of as early as possible, right at the point of diagnosis, and seeing, who is going to develop more formal language by age 5 and who is not, or is going to continue to be non-speaking. And some barriers that we've encountered is that it's been really difficult to find young toddlers who are getting diagnosed early. And we as providers, but also we imagine all of the providers in our community, want the diagnostic process for families to be accessible, to be informational, and empowering. But really, sometimes what we have encountered, or what our families have told us, is that sometimes that diagnosis journey can be frustrating, it can be slow, confusing, it's very emotional, and sometimes expensive. And a lot of those problems stem from some things that we talked about earlier this morning, right? So we have limited providers who are trained and specialized in this area, who have the self-efficacy, right, that we talked about earlier, or clinical competence to diagnose autism. Because of that, then, we have these really long wait lists where families are telling us, we're trying to get in at Children's Mercy or KU Med, where there are fantastic providers who do these evaluations, but we're told there's a 12, 15, 18-month-long wait list, right? Some families reflect on not feeling heard or understood by their providers, or they have to ask their pediatrician or other educators or clinicians in their lives multiple times to seek a diagnosis, or they don't feel like their problems are being accurately understood. And that can also result in some conflicting information from different providers in that family's life. And then sort of the biggest logistical barrier of all, insurance, which can make things very expensive and logistically confusing for families as well. And we may be sort of preaching to the converted about this, but sometimes we do have to sort of sell why we think that early diagnosis is important, right? So hopefully everyone can kind of see this okay, but the idea is that a diagnosis, especially early diagnosis, represents information for families, right? That information can lead to more family support and community among other families who have children who are autistic. That can also lead to access to specialized services. And it can help guide then treatment decisions for those young people. There may be specialized services, like if families want to seek ABA early in toddlerhood, that you kind of get access to once you do have an autism diagnosis, or insurance makes it easier to access those services if you have an autism diagnosis. And then clinicians might be more attuned to treatment decisions that are specifically research-based or evidence-based for autism. So those things are important to, ideally, which is what we all want, lead to better early intervention outcomes. And this is backed up by literature. So early diagnosis can lead to these very early interventions, which are then associated with, again, like we said, those better long-term language, communication, social outcomes. It's also specifically, we think about social communication and language a lot, so it's also related to greater improvements in social communication skills over time. And those kids who are diagnosed early are also more likely to access things like mainstream classrooms once they reach 5 and up in their general education. And it is sometimes it feels like, again, I'm probably preaching to the converted, but there are early signs or traits of autism in toddlers that we can see and that we can use to inform diagnoses. There are things that are sort of what we call positive indicators, and there are things that children may show difficulty with or are challenging. So some of those difficulties might be, and some of the things we think about with joint attention skills, like were referenced earlier in this morning's talk, gestures and pointing, mutual gaze with another person, play skills, babbling. But there may be also those positive indicators or presence of other behaviors that parents might be attuned to and be like, what's going on here? So things like echolalia or repeating back language without using that language spontaneously on their own, using other people's hand as a tool to access the things that they need or to request, special interest or excessive interest in certain objects or activities, strong interest in or aversion to sensory experiences, or sort of maybe unusual movements of hands and fingers that persist past like infancy when you would expect them. So these are all things that we can see in toddlerhood that may kind of raise those flags for autism, right? And there are some resources that I like to use with families that sort of demonstrate what these traits look like in very, very young kids. So I'm just going to show an example of one of those. These are a collection of CDC videos called Genetica Lens. I don't think they actually have them on the CDC website anymore because they are much older, but they are still available on YouTube. I still think they're very useful and can help illustrate or demonstrate these things to families. So here's an example of two twins, actually, who, again, are 1 year, 7 months, or 19 months old. So we're going to see our first twin at the beginning, and pay attention to his behavior.
Yeah, it fell off. That's right. Here it is.
Uh-oh. And now we have our second twin.
Push. Good boy. Ready, set, go. You can push. Oh, stay there. Go. Stop. What? Good. Go. Look, here it is. Take the train. Stay up here, please. Good boy. Ready, set, go.
And then again, a video like this can be really useful to help compare and contrast things that we might typically expect in development versus things that we might not expect in development, right? So again, all of these little traits like we talked about, like one I saw here was like a more sticky interest to that train and playing with the parts of it and looking at it rather than sharing the experience of playing the train with his mother, similar to what the first child did. There are also some other like absence of behaviors that we can see, right? There's less joint attention, there's less mutual gaze with the parent, and these things are visible. We just have to be trained and attuned to see them and to identify them and put words to these behaviors that parents may be seeing and are like, I'm not so sure that my child is developing the way I expect them to. And so again, some of these video examples and resources are really helpful to, there we go, are really helpful to use as like kind of information gathering and discussing with families what they're seeing in their own children. So I put some examples up here that I like to use with families. Again, those early autism case training videos. There's a milestone tracker app that is available on the CDC that is really helpful for young families to be able to do that information gathering themselves as a more empowering role for parents. The Baby Navigator and Autism Navigator through the First Words Project I'll also highlight as really good resources They have fantastic handouts, especially related to early communication skills and gestures, and also video resources that then parents can go in and learn more about these signs, traits, and the general course of development themselves. So these can be a good kind of ally and communication tool between providers and families.
Do you mind if I pop in real quick?
Yeah.
Your local district's parents as teachers is also a phenomenal resource. We have had multiple children come through our study that their parent educator noticed something was going on, talked to the parent, and sent them our way. In every instance, they've been correct. So that is a resource that I think a lot of people don't realize is there, and it's free, and they come to you.
Yeah, absolutely. So then after we kind of identify these maybe early signs or traits that we're seeing in kids, sort of the general next step that a family might encounter is a screening tool. Typically this may be done at a well child visit with a pediatrician. It should be done at an 18-month well child visit, or it may be conducted by that family's speech therapist, developmental therapist, early childhood educator if they're already receiving those services, right? So I highlighted, again, a few that I think are useful. Like Dr. Stoll mentioned the STAT this morning. That's pretty widely used, an evidence-based screening instrument. There's also a few here, the Toddler Autism Symptom Inventory, the SORF, the Systematic Observation of Red Flags in Autism, and the Early Screening for Autism and Communication Disorders instrument. So there are all these what we call screening things available to tell us, okay, should we be concerned? Should we not be concerned, right? It's kind of a positive, negative, rule out, rule in type of tool. And I also linked, if you just Google the Informed SLP, autism screener options, you'll find this article that then lays out some of these tools and others and the evidence behind them and why they may be useful to clinicians. Even if you're not an autism diagnostician, you can still use these screening instruments to help families on their pathway, right? And then we usually run into this barrier, right? Which is this big myth that autism diagnoses are not accurate or stable until children are 3 to 4 years old. I don't know if people in this room can relate to this or have heard this before from families that have encountered this information or from other providers, but we've run into this with our families a lot. Someone will come into our research study and they'll say, hey, I have concerns for autism, or they say, I know my child has autism, or I know my child is autistic, but I talked to their pediatrician and they said we can't do anything about it until they're 4. And this simply is not accurate. So you can diagnose autism really as early as around 18 to 24 months for that to be a stable diagnosis. There are obviously some exceptions, and like Dr. Stoll was kind of alluding to this morning, there are some more complex differential diagnosis cases, and there are some more, I like to term unambiguous cases that we encounter, right? So, and again, this is backed up by research. So specifically for children who come from what we call multiplex families, or from children who are at an elevated likelihood of receiving a diagnosis for autism, that usually means that their older sibling is autistic, and so that they, as the younger sibling, have a higher likelihood of also being autistic. So in that population of those elevated likelihood toddlers, those diagnoses made as early as 18 months are very stable once we see those kids again at 3. This is especially true for children with lower language abilities. So what that means then, if you have a child come across your caseload, they might have an older sibling, they're 18 months and they're not talking yet, right? Or the parent is concerned, my child only has a couple words, they're losing words, they're not using language with me as frequently as I think. That child is one where you can say, okay, maybe we can get in for early diagnosis earlier, right? The stability of diagnosis in the general population, so even outside of this elevated likelihood population, even as young as 12 months, really once kids are walking, is still strong. And that has a higher diagnostic stability of other more high incidence disorders such as language disorder or a generalized developmental delay, right? So we have this myth, again, I think a lot of times that comes from a problem with self-efficacy, right, of providers of saying, we can't actually do this until kids are older, so we're gonna wait and see, stick with your early intervention provider and then come back and see me later. But that's not really gonna be an optimal choice for families, and that ends up being a very frustrating process. So then, if we kind of get past that barrier, then we get a formal evaluation or diagnosis. And there are a few tools that are really useful, specifically for toddlers. One is called the ADIR. It's an interview with families. And then we have like a photo here of the ADOS. Again, that was alluded to earlier, and that is a direct assessment, a direct play-based, essentially language sample with a toddler using lots of different activities that are supposed to really pull out these different traits that we're looking for. And I'll even point to, even if we don't have these tools available to us, a test, which, you know, Kourtney is going to speak to, I think, a little bit later about what this diagnostic odyssey generally looks like. A test does not diagnose autism. A clinician diagnoses autism, right? And I think we really get like hung up on the availability of these tests or being trained on ADOS, or, you know, there are ways to diagnose autism reliably and stably. And that is based off of our DSM criteria. So something like an ADOS helps illuminate those traits that help you check off these boxes for the DSM criteria, right? And those are differences in our first main area, which is social communication, and our second main area, which is restricted and repetitive behaviors. And we have to check certain boxes of traits in both of those categories, make sure that those behaviors are not better explained by something else, and then we can make a medical diagnosis of autism, right? And this is also when we kind of run into our second big myth that we see a lot, both like in our community on social media, that parents tell us, is that you need a developmental pediatrician to diagnose autism. And why is that a problem? Because we don't have a lot of developmental pediatricians. And typically, only 7% of developmental pediatricians practice in rural areas, which is particularly pertinent to us in Kansas and Missouri, where we have a big swath of the population that does not live in Kansas City near KUMC and does not live in Columbia near the Thompson Center and may not have access to these professionals. But actually, providers who are, it is again in our scope of practice to diagnose autism, that doesn't necessarily mean they have specialized training, but they could, are licensed clinical social workers, pediatricians and family medicine doctors, like Dr. Stoll talked about earlier, child neurologists, clinical psychologists, and speech language pathologists, though there are some like restrictions depending on your state and what insurance will cover, which is a whole other gamut. And these providers need, again, training and self-efficacy in an autism diagnosis to, you know, ethically provide that diagnosis to families, right? But it doesn't have to just be a developmental pediatrician. And often it can be a team of all of these people working together to make sure that they're providing the best possible diagnosis for someone's child. Okay, and so I'm gonna swing it over to Kourtney to talk about these different diagnostic referral pathways that we've already been alluding to.
Yes. So when I think of individuals that are coming to me in clinic, I think of different ways of how I get them, right? And I kind of divide it up by age ranges. So the first one I look at is the birth to 3. So you've already talked a bit about infant and toddler services. So these are some of the ones that we have here in Kansas. We call it Tiny K. In Missouri, it's Missouri First Steps program. Also, Parents as Teachers is another wonderful referral pathway. We alluded to your pediatricians. They should be doing screenings right at that 18 months to see if there's any signs or symptoms. And then sometimes families are lucky enough to be able to work with like a speech and language pathologist that could send them on, or maybe even their daycare provider. I know that when I was at KUMC, they have some really nice training initiatives for preschool teachers and trying to help them understand what are some of those signs for autism, and then noticing it first off, right? But then second off, like, how do I have that conversation with a parent? Because that's hard, right? Like, it's sometimes we can see things, but then how do I actually articulate it to you to where, you know, you feel confident in your ability to move forward with that next step? And so, so some of these people are kind of our front line when they're younger, but then also, I know this is a toddler talk, but I also think a little bit more about they might get identified, right, within the school settings. But I think the really important thing that I want to talk a little bit about is the idea of self-referral, and I'll talk a little bit more about it in the next slide. I know when I've been in a few different institutions, and sometimes we weren't able to take self-referrals, and by that I mean like the parents, like they have a concern and then say, sorry, you have to tell your doctor, give us that referral, and that is a barrier, you know, because then I have to wait for my doctor's appointment, or I have to wait to get into like a psychologist or speech and language pathologist, and it can be hard. So anyways, I'm going to talk about that in just a second, but at the gist of this, after we have identified some concerns from these folks, there's lots of paperwork families have to fill out. And then they finally get to see us in a clinic, and hopefully, you know, some of us are going to be doing some of these assessments, but I think we'll probably talk a lot about them later on. They take a heck of a lot of training, and they're expensive to get to, so that could be another barrier. But this is the gist of how families usually come to me in clinic. So I apologize if I left things off, but this is how I kind of see it. All right, so talking about these self-referrals, I think this is a really interesting paper. So again, focusing in on toddlers, the sample was about 50, well, a little bit more autistic individuals in the sample than non-autistic, but what the gist of the study was, it was really fascinating. I'm gonna grab that paper here. So they had parents fill out questions, and so here are 3 of the questions, and then they had them complete the MCHAT. So are y'all familiar with that checklist? Okay, cool. Please briefly list any concerns, worries that you have about how your child has been developing, thinking about walking, speaking, playing, or behaving. So that's one of the questions that they ask, and the parents got to write it in. What about concerns about your child's development? So kind of a bit more broad there. And then what are the things that made you concerned about your child's development, and how old was the kiddo at the time? So they first asked them those questions, and then they had them fill out the MCHAT. And I think what the really important notion that I want to share is that 93% of the parents who said that they had concerns also screened positive on the MCHAT. So they're noticing differences, right, in their development. But I think, again, there's this myth, the wait and see until they're 3, which is obviously not ideal, because it does then push up the rate, the age of diagnosis. So the other really interesting thing about this study is that of those 93% that had the concerns, 94% of them got an autism or a developmental delay diagnosis. The other kind of interesting thought is that but only 5% of the parents that got the autism diagnosis said autism in those 3 questions. So we're noticing differences as parents. We might just not be calling out like that it is autism, but we're certainly seeing it. And so that's why I really appreciate some of these clinics now taking self-referrals. I think it's quite important to really listen to our parents, because we do know we are experts in our kiddos, right? All right. Next slide I want to share with you. This is some results from the National Autism Data Center, and this is kind of sad. The data is from 2021, so potentially maybe it's going to be a little bit better, but what we know is a national average age of diagnosis is 4 years, 9 months in the United States. Kansas, we're doing better, right? Missouri, not so much. Always love to throw up, Mizzou and Kate's thing, right? But the next graph, what you'll see is the age of diagnosis. I just picked out Kansas, so Kansas is in blue, and then the state, United States, is in gray. But just looking at the age of diagnosis, so it's still quite high when we know that we can accurately diagnose autism at 18 months, or sometimes, the 12 to 14 months, if they're very crystal clear traits. So how do we get this down? Again, I like Dr. Soule's talk about thinking more creatively about how to see and meet these kids in the community. one that was really striking to me here was the girls in Kansas. So our average age for a diagnosis in Kansas is 6 for girls. It's quite high, right? So something we need to maybe think a little bit more about as well. So of course, if we can't get the diagnosis, unfortunately in the world that we live in, you have to have a sneaking diagnosis to get services and interventions. And so thus, the average age for intervention is 4 years, 9 months. So a lot of work, a lot of creative thinking to maybe go into some of these numbers. That's me. That was quick.
So, barriers preventing early diagnosis, that big one, the elephant that's standing in the room, is that wait list. I am up close and personal with the wait list right now in my life because I'm constantly giving parents information about wait lists. And the average wait list time from that intake call, when they call and say, hey, I want to get my kids screened, to the time that they get an evaluation is 12 months. That's less than what it was when I first started the study. It was 18 months when I first started the study. But that's too long. So why is it so long? Right now, we refer typically to our 2 well-known testing sites, KU Med and Children's Mercy. They take every insurance, including both of their state insurances. That is the popular place to go. What a lot of parents don't know, and thus a lot of providers don't know, is that there are a lot of smaller centers in mostly Kansas City, unfortunately, that do accept insurance and do have a shorter wait time. So what does that look like for them? You could go, I have a list of 10, maybe 15, and of those, the wait list for someone who wants to use insurance, who wants to bill insurance, is higher than the wait list of a family that will just private pay, that will just pay cash credit check. Right now, the wait list for private pay is 6 weeks to 2 months. That would be awesome if we all could just pull out $900 and say, let's do this, but we can't. So then if you're wanting the provider to bill your insurance, your wait time goes up to about 4 to 6 months at these smaller private centers, which is still better than waiting for the 12 to 18 months that you could be looking at one of the larger centers. That is something that I do want to talk about here in a little bit when we jump into the brainstorm session, is how do we get providers, how do we help families know that these other centers do exist and they are accepting patients. And then I wanted to touch back on self-referral. Every place that accepts insurance requires a referral. If you are coming in and you're going to self-pay, you don't have to have a referral. But that insurance kind of stands there as a big barrier of you have to have a referral. And then that jumps back to, unfortunately, with a couple of the kiddos that we've had in our study, the pediatrician doesn't see a problem. And so they have came to us saying, you're our last hope. Please, do this assessment. And this was before we had Kourtney. And so Olivia was doing the assessment. She's trained in it. She's research reliable, but she can't give a diagnosis. So we're writing up reports for them to take to their pediatricians, who are then giving them the referral based off of our reports. And then they're moving on to get their diagnosis. But we're supposed to have a parent's perspective, but her babysitter backed out. So what's fun here is that you have 2 people on your panel who do have that lived parent perspective. I have a son who is going to be 16 in May, and he was diagnosed at 6. He checked every box that you needed them to check for development to not have autism. And I said, he has autism, over and over. We were on beds for ADHD at 4. We were dealing with suspensions all through kindergarten in the school that would not help. It was a struggle. And I remember telling my pediatrician, there's something more here. And she said, well, he's probably ODD, oppositional defiant disorder, and sent us to Shawnee County's only mental health agency for children still. And I went there and we walked away with ADHD and DMDD, disruptive mood dysregulation disorder. He was on Zoloft, he was on Risperdal, he was on Abilify. He went from being a tiny little guy to gaining tons of weight. We were taking him off of meds, putting him on meds. But I went to his psychiatrist, who I had spoke to so many times, who was giving these meds, and I said, there's more here. And we sat down and we went through the DSM, and that is how he got his diagnosis. We never tried to get services through insurance, which is why I never had to take him to an evaluation center. This was purely so that we could get support at the school so that he could have this diagnosis. So for us, we didn't have to have that wait, but we had to deal with the, oh, he's already talking. He's walking at, 10 months. He's doing all the things before he's supposed to be doing them. I'm like, that's great, but he cannot do the things that he needs to do, which is play with people or, sit for 5 minutes while we're trying to do something without having a meltdown, or go into Sam's Club on a Saturday without laying on the floor for 15 minutes while parents walk me and say, you should just discipline that kid. So that's kind of our journey. We are still going through it. It has been an interesting fight for school, and I was actually going through my bachelor's at the time when he got his diagnosis, but being a special education teacher and then having a child in special education was a unique perspective that I was able to bring at the time. And I also was very, very knowledgeable of special education law. So I was able to advocate for programs to be created at his district that have now, I think there's been like 15 kids who have come through the elementary program now. So that has been like a big thing for me. My mom heart has been very happy because I advocated for some programs and got them in place, and those programs will be able to follow those children all the way through high school now, because he is in high school and he's doing okay. He hates school, but that's just him. Do you want to talk about yours?
So, before we all kind of, I'm going to skip ahead a little bit, chat together about how we can maybe creatively think to alleviate some of these problems or myths or barriers in our own community, I wanted to highlight some things that are happening elsewhere in the country. Creative solutions that other people have come up with that I think are really interesting. So the first kind of strategy that people can do to alleviate some of these barriers is identify the point of entry to clinical care. So how do we see kids earlier and catch them earlier? For a lot of children, especially children who are not talking, one of the first providers that they go and see is actually an audiologist, because they need to rule out that their child can hear, right? Or maybe their parent is concerned that their child can't hear because they're not responding to their name, they're not talking very much, they're not looking at them, right? So a team of audiologists, pediatric audiologists at Vanderbilt University Medical Center saw this coming through in their own practice, and they decided to train their audiologists to screen for autism during their hearing evaluations. Because otherwise what they would be doing is just kind of silently thinking, this child probably has autism, but not really being able to say anything or do anything about it. And I think a lot of professionals, daycare providers, early childhood educators, SLPs get stuck in the same trap of knowing and not communicating anything about it. And so what happened, and there's a really interesting article in Journal of Hearing about this that I've sort of screenshot down below that you can read, is that of those positive screens that they implemented in their program, 81% of those referrals resulted in an autism diagnosis. And they were able to directly refer those children to a team of SLPs in their medical center that were trained to diagnose autism, and that diagnostic pathway just got a lot shorter, right, and a lot quicker. Another strategy we can take is to increase the number of trained providers. We can expand who is allowed to diagnose autism. There's a really interesting research project in Illinois called the Reduce the Wait Project, where researchers have gotten sort of permission from their state and from their state's insurance and licensing to train SLPs and developmental therapists, so clinicians who are already in the EI system, to provide autism assessments to children enrolled in EI services. So if that early intervention provider, again, thinks this child very likely has autism, but they're not traditionally trained to diagnose it, now they can do something about it. And they have found really great diagnostic agreement across a huge number of the children they've evaluated. And again, I think that speaks to the number of sort of unambiguous cases that we come across where we don't need a 3-hour-long or 6-hour-long evaluation in an academic medical center to tease through. And they've reduced their wait time for the clinicians that are operating within their project from 15 months to 1 month. That's a huge cut through, right, of that big, long diagnostic journey. And then some of the other things we've already kind of heard about this morning are just kind of geographically increasing the number of trained providers in our area, right? So we've heard about Project ECHO, which is doing this across Missouri, but also in plenty of other states and communities to train providers. And then the University of Arkansas Medical Sciences program is also implementing a similar model called the Cobalt Educational Training Program, where they find teams of pediatricians and SLPs, or pediatricians and EI specialists, that work together in rural areas in Arkansas to become the autism diagnostic people in their county or in their area. So these are just some things that I wanted to highlight so that we can sort of get our brainstorming going of, you know, whether y'all are providers, researchers, family members, self-advocates, what you see as the biggest barriers to autism diagnosis, and maybe what we can do to improve that early diagnosis. So I'm interested to hear from people of what their thoughts are in their community. Yeah.
I'm in Salina, and there's only like 3 people that can diagnose in Salina, so it's really hard to actually get kids in because the wait list is extremely long. It's like a year to 2 years.
Yeah. So that kind of speaks then, I think, to this point of like geographically increasing the number of trained providers in an area like Salina, where people may not have the ability to travel to Kansas City or Columbia or wherever to get their diagnosis. Yeah, what else?
I have a question.
Yeah.
Is there a list of states where ECHO are?
That's a great question. And I think on the ECHO website, they have some more information. If you go there to ECHO Autism Communities, about where they're located, where some of those hubs are.
So, no presentation. I think that there is an issue with the type of questions that they're asking those documents once you try to get into this waiting list.
Mm-hmm.
When I look at the early signs that you refer at the beginning, and I remember the questionnaire that I had to answer for my daughter, they really do not match. And the problem with that is that once they contacted us, our daughter did not like fly like high in the radars because she was not really knocking her head against the walls or other things. She was not acting in some harming behaviors.
Mm-hmm.
And in the end, we were diverted at that call to speech therapy. Not even put it in the year waiting list. They kind of like rejected us after having all these steps. Maybe I should have pushed forward. I mean, you don't know as a parent. Would be now in speech therapy, but I still think like about that critical moment after navigating all this documentation, the questions that were asked, and the fact that the issue of gender and how this autism might look like in boys and girls and in between need to be addressed somehow.
Yeah, that's a really great point that we didn't really touch on, except for the fact that, like Kourtney mentioned, in their self-referral program, right? Very few people use the words autism, right, when they're self-referring. Or there's this kind of ships in the night phenomenon where maybe the provider and the parent are both communicating about the same thing, but they don't have the common language in those screening questions or in their own referral to kind of match up, right, and know that actually we're both talking about autism, just maybe in a different way. And so, maybe like improving what that screening process is as more of a conversation with families to find that common language so that you don't get diverted somewhere else, which is really frustrating to hear.
And I think a lot of the screeners, like, so for example, the stat is quite good, but when you have a kid, I don't know if your daughter had language, but if she had, sometimes when girls have a language and they have some, social, initiation, some joint attention skills, they're much easier to miss in clinic. You really have to spend more time with them, and so they end up as false negatives on those screeners, and they go on later to get that diagnosis. And so I think it's a really good question that, like, I think research is not. I think there needs to be a bit more about it. I think, Steve, you're starting to talk on false negatives. And kind of thinking about what is the phenotype of false negatives and how do we make sure as clinicians that we don't automatically rule it out just because somebody has language or they have like higher cognitive abilities at that first time. It's a really good point.
Thanks, Suzanne. I'm a speech pathologist in Wichita, Kansas, and I work in a private clinic. And I see kids very early, luckily. One of my barriers right now is just recently I referred a 2-year-old, 2.5-year-old. I have to go through referral with the doctor. And I spoke with the doctor and I said, I'm seeing characteristics of autism very early on. But finally the doctor, went ahead and made the referral. And the military, they are doing like online evaluations, which I don't know how that's going to work yet. But the doctor then told the parents, I don't know why it's important that we do this. I don't know why. And so I think I want to find a good way to speak with my physicians and provide more information. I don't know, is there an ECHO team in Wichita? I thought Wichita State had one, but
So I'm not sure the answer to that
I
question.
don't know, yeah.
I mean, what is a good what are, as a clinician, that barrier with the physicians, I would like to do more of that.
Yeah.
So, because I get a lot of toddlers,
Right.
which I'm really lucky, I feel like. I send a lot of referrals in. But I do feel like there is a little bit of pushback because they're so young.
Yeah, I think there's some big
I was
contribution to
going
that.
to say this. Dr. Brady Patrick used to be in Missouri, but is now at Wichita State.
I just
She's
talked to
a
her.
fantastic autism expert. I think it's
Okay, she's doing an evaluation for me right now.
There you go.
It's an older kiddo, so he couldn't get in anywhere because he's older, and the wait list for the older kids is longer than the younger kids.
Yes.
So, okay, thank you.
Yeah, no problem. Yeah, and some of that too, I think, to this point of like partnering with a pediatrician that is sort of like speaks your language, right? Is then identifying how to present that information to other pediatricians or other providers in a way that is going to be compelling to them. Like, I have my spiel that I, can talk with families about why I think early diagnosis is important for them, and why I think that's a good route to go. But again, that argument might not be as compelling to the different person that you're talking to, right? And so I think understanding, pediatricians may not have the understanding of the nuance of the system, and then, what a diagnosis does for you to fill out paperwork for school and to get insurance waivers and all of that important stuff. And so I don't have a perfect answer to that, but I'm sure, like, there are other people in this room that do.
That's what I mean.
Yeah.
That's the hard
Have, like,
part.
your key ally, right?
To do that.
Yeah.
So I'm a nurse practitioner, and so kind of going off of what you said, a lot of the clinic that I work in, a lot of the doctors, providers are like, well, here's a list of people that you can go and get tested for autism. it takes a lot of time for screenings and evaluations, and unfortunately, you know, numbers. We've got to move those patients through the clinic, and so I think that's a big part of it. Another thing is there's not enough training, I don't think, for nurse practitioners, doctors, PAs. If I was able to, in the clinic I worked in, I think I would be more willing to, if I had the training, of course, be able to work with families and help them get that diagnosis that they so desperately wanting or needing.
Right.
But a lack of training, a lack of understanding, you know, I don't know if could be a requirement for, you know, these pediatricians, family doctors, nurse practitioners have to have a certain amount of CEUs for
To
understanding
kind of
autism.
increase the floor of
Yes.
self-efficacy of what they're
I mean, we have to have a certain number of CEUs for, you know, the DEA. So
right. That's a great point.
yeah.
I have a question.
Yeah.
Early on, you said something about it's not optimal for children receiving services with their early intervention provider. You don't understand that?
Yeah, so that might, thank you for allowing me to clarify that. So it's important for children to still continue to get their EI services and have that continuity of care, right? That is important. What helps in addition to those services is having that diagnostic information that can help maybe guide those services in a way that is going to be most beneficial for that child. So allowing this kind of wait and see approach without that extra information is not necessarily fair to the family or to the clinician who is working with that child, who may be needing these extra resources to meet that child's goals, right? Or to know how to work with other professionals in that child's care team to maybe focus on those goals or traits of autism that are really important for that family, right? So it's less about just having EI is not bad, but again, it's a missed opportunity for both the family and the provider to have that diagnosis and access to other specialized care and to help guide your treatment goals. Does that help clarify that a little bit?
Yeah, I heard it really differently.
Sure. Yeah. No. Thank you.
I hate to cut us short,
Yep,
but I want to make sure we all get to our 11 o'clock session on time. Please make sure you scan that QR code in your program, or if you want to go and flag me down. But let's give a hand to our presenters. Thank
Let's drink all that water.
Yeah. Thank you.
Awesome. I will send that to you. It'll probably be Monday. Awesome. So much. Yes.
I got mine off.
It's kind of a lot better, I think, because she's singing and working so hard.
Yeah. What color?
Okay. I get qualified musician. We can graduate college. Remember. It was actually really helpful though, because I learned a lot. Yeah, I mean, like, I take it as it is.
Research or data, but I don't know if you're also collecting any.
Yeah, so I'm not, but I don't know data on what specific.
Data on, for example, diagnosis or symptoms or phenotype, I mean, there has to be some type of information, but I wonder those being actually just.
I know, yeah, I know. So I used to run an echo back when I was at Mizzou.
Oh.
And we had like forms that they would submit to us, and I don't know if we did data analysis or anything like that. It was an extra free.
Okay.
So, yeah.
But that's something because I think this is a very interesting. I'm sure they are thinking about that. I will follow up with her because this is a fantastic opportunity for taking a look at some of the research-related questions in this context because of the way that the diagnosis is being done, the kind of recruitment. It's a different population.
Yes. Yeah. And there, yeah.
Thank you.
Yeah. I think the one thing about echo is that there's no validation studies. So the parents are not bringing them back in. So like you're diagnosing an echo, like bring them into another system and blind.
Yeah, and diagnose validate.